Good evening, everybody. Welcome to Dil Se Dil Tak, a public awareness program regarding the healthy heart. This is Dr. Mrinal, your host for today. We have some alarming statistics. Indians fall prey to cardiovascular disease about 10 years ahead of the way. Not only that, every 33 seconds, one person is dying of cardiovascular disease in India. That's quite alarming. But IPCA has launched an initiative to circumvent this problem. It has partnered with the renowned medical community, Fraternity of India, to launch a patient awareness program which actually can teach them about the healthy heart. Today, we have an elite panel of cardiologists from Kolkata who are of national and international repute, who will talk more about healthy lifestyle, healthy heart, about the heart attack, how to prevent it, and what are the steps we can take. I welcome all of you today. First of all, we are transmitting from the city of joy, that is Kolkata. So we would like to start with a video about the city. Let's see what it had in store.
Kolkata, the capital city of West Bengal, had been nicknamed as the City of Joy. A warm and welcoming city. It thrills the outsiders at first and then seems to become a part of their soul. The City of Joy, over years, due to changing lifestyle, like other parts of India, is also witnessing a surge in cases of heart disease at younger age of 30 plus. But Kolkata, the land of leaders and thinkers, have also taken a step forward in controlling heart diseases in India. It all started way back in 1948, when visionary cardiologist and ex-chief minister of West Bengal, the Bharat Ratna, late Shri Dr. Bidhan Chandra Roy, along with like-minded colleagues, set up Cardiological Society of India. Over the years, Cardiological Society of India, which is popularly known as CSI, headquartered out of Kolkata, the largest body of cardiologists in India, with over 4,000 members, have been instrumental in getting quality cardiac care for Indians. Today we have the privilege to have fellows of CSI on our talk show, Dil Se Dil Tak Healthy Heart, a public awareness initiative by IPCA Laboratories Limited.
Thank you very much. First of all, I would like to introduce somebody who is, needs no introduction. He is Dr. P.K. Deb, who is a senior super consultant cardiologist. We would like to see a video about his message, what he does, and what message he has for everybody. Let's see the video.
Today we will meet an eminent personality who is an engineer at heart and doctor by profession, whose journey to excellence in medicine is not by design but by destiny. It happened few years back when a young man saw how a doctor becomes a savior of life and is a source of hope as well as happiness in lives of ailing people around him. That inspiration inspired the heart of a young doctor who, with blessings of his mother, went on to become the renowned cardiologist of India. Meet Dr. P.K. Deb, a consultant cardiologist from Kolkata, who has over 30 years of experience in the field of cardiology. Dr. P.K. Deb, post his MBBS and MD, did DM in cardiology from Calcutta University. Dr. Deb was the chief cardiologist at ESI, Postgraduate Institute of Medical Sciences and Research, Kolkata, where his mission was to bring quality cardiac care within reach of poor working classes. He has the distinction of being the president of the Cardiological Society of India for the period 2012-13. He is a fellow of the Cardiological Society of India and also a fellow of the European Society of Cardiology. Dr. Deb served as associate editor of the Indian Heart Journal and has over the years contributed many articles in other peer-reviewed journals. He is renowned globally for his work in the field of cardiology and is invited as faculty in numerous international medical conferences. Let's hear Dr. P.K. Deb's vision on how cardiologists from India can join hands in the development of quality cardiac care guidelines for Indians, and also what as patients we should do to keep our heart healthy.
I would like to welcome sir to the stage, please. I would like to take a seat, sir. Sir, we have a very welcome first of all to the show, Dil Se Dil Tak. We have a pertinent question for you. If we see different aspects of the lifestyle, if you compare Indian lifestyle with the Western lifestyle, let's take US. if you go to US, we see people eating so much. But still, when it comes to cardiovascular disease, we are ahead of them. It's 10 years ahead, we develop cardiovascular disease. Why is it like that in India?
Look, if we compare and contrast the prevalence of cardiovascular disease, what it is right now and what it was decades back. It was in USA and Europe, the disease was more common compared to what it is today. But with lifestyle adjustment, with identifying the risk factors for the development of cardiovascular disease in US and Europe, with their own studies, they manipulated the risk factors and did some wonder regarding the incidence of cardiovascular disease and risk factor modification. But when we translated our experience, what we gathered from USA and Europe, and by not getting our own experience, what we did, we made something wrong. So by Framingham study, which we blindly followed, it was not reflecting the risk factors which is prevalent in India, which we realized after some time, after applying the Framingham experience in Indian scenario. We discovered that Framingham study or Framingham score could not predict Indian heart disease much more. And so we started to understand, have our own insight and found that the basic problem is probably lies in the Indian genes. The South Asians are much more prevalent to the development of coronary artery disease and its complications due to the sick gene that they carry. In India, it is the genes primarily, then comes the other gene-related diseases. Say diabetes mellitus, very common in this part of the world, probably the highest incidence. Say the truncal obesity, say the risk factors or other anxieties and tensions, BD smoking, cigarette smoking, then carbohydrate intake habit. Then I should say that even the cooking habit, even the vegetarians, by cooking the vegetables, they spoil the folic acid, thereby increasing the homocysteine, thereby increasing the incidence of coronary artery disease. So all these factors contribute to, I think, the lifestyle, the genes, everything contributed to high incidences of coronary artery disease, which we are encountering today. We now know what is our risk factors. We are trying to identify our own risk factors. The CSA will come forward with our own factors, which we'll definitely find out in very soon. And we will have our own cardiovascular science.
Okay, so it's more like related to thrifty gene as well, which
yes.
Okay.
Yes.
Okay, thank you, Dr. Deb. Definitely we'll come back to the panel. We'll definitely like to shed more light on it.
Oh, thank you.
Okay, thank you.
Yes. I wanted to practice and understand cardiology in India, in Indian perspective. That means I want to understand the epidemiological data in India, the disease pattern in India, the healthcare delivery system in India, in metro cities, in middle income group population, in rural population, in co-rural areas, in tribal areas, how they get the medical help and everything. So I want to in fact Indianize cardiology in India, and all throughout my medical career, health career, during that 40 years I followed the same system to Indianize the system. And for the patients, my message is very simple, that in Indian scenario, when the population is too large and the amount of money is too small, the prevention of the disease is more important than taking care of the disease after it develops. So we should emphasize more on prevention of the disease than on treating the disease. So we should take care of all prevention methods, primary prevention, secondary prevention. That should be a top priority. That is what I believe, and it should be practiced by everybody. The healthcare professionals, the doctors, the consultants, super consultants, even the politicians. Everybody should even the schools, the school children, school teachers, everybody should understand the importance of preventive aspects of the disease in India. That's my top priority when I think about disease and healthcare distribution system in India. One prevention tip will not fit in every disease, because the preventive measures that should be followed for rheumatic heart disease will not be applicable for hypertension or say ischemic heart disease. So disease pattern, each and prevention pattern will depend upon the disease pattern, which disease we are planning to prevent. For rheumatic heart disease, in fact, prevention is very difficult. We should improve the housing standard of the population and see that the overpopulation in the houses should be prevented as much as possible. And this is in the solution. More is upon the government and the politicians, less upon the doctors. But doctors, what doctors can do, doctors can arrange for this prophylactic penicillin. But unfortunately, that penicillin is also not available most of the time in the country. That is another story. And then for rheumatic heart disease, in fact, there are several lifestyle modifications that should be properly promoted, that should be properly publicized, that should be properly followed. And for other health cardiac diseases, we should know the risk factors. Risk factors should be properly promoted. Risk factors should be properly understood. We should know how to identify the risk factors, how to prevent the risk factors. These are the things that we should try to do in our country. And this will help us a lot, because after the development of the disease, it becomes more of a business, I believe, than it. But if we want to take care of the population as a whole, we should take care of the preventive strategies. We should emphasize on the preventive strategies, primarily, secondarily, and also tertiarily.
Very nice message from Dr. Deb. Next, I would like to introduce somebody who is a cardiologist of international repute, has been a past president of Cardiology Society of India, Dr. Anjan Lal Dutta. First of all, let us see the video and a message from him.
Commitment meets excellence and passion in a doctor who continuously upgrades himself in the field of cardiology for bringing quality cardiac care for his ailing patients. A scholar doctor who had been the topper in all his exams, including MD and DM examination from Kolkata University. Meet Professor Dr. Anjan Lal Dutta, who is currently associated as Clinical Director and Interventional Cardiologist with PLS Hospital in Kolkata. Dr. Anjan Lal Datta's penchant for sharing knowledge and experience with young cardiologists made him serve as Honorary Professor of Cardiology at Vivekanand Institute of Medical Sciences at Kolkata. Dr. Datta has published more than 60 research papers in indexed journals and textbooks. He is a regular invitee as faculty at various national and international cardiology conferences. Dr. Anjan Lal Datta is an active member of the Cardiological Society of India, CSI, and in the past has served as President of Cardiological Society of India. He is also a Fellow of the American College of Cardiology, FACC, and also a Fellow of the CSI. Further to his credentials, Dr. Datta is a recipient of numerous prizes in academic and research field. To name a few are awarded medal for best thesis work by the Institute of Postgraduate Medical Education and Research, IPG-MER, Kolkata in 1986. Best Paper Presentation Award by IPG-MER in 1986. Best Paper Presentation Award at All India Young Scientists Conference organized by B.R. Singh Railway Hospital at Kolkata in 1988. Awarded Medal for delivering Dr. Dhanopati Panja Memorial Oration in 2000, organized by the Ex-Students Association at Calcutta Medical College. Dr. S.C. Bose Memorial Oration Award by the Cultivation of Science, Jadavpur University in 2003. Dr. Amiya Chatterjee Memorial Oration Award, organized by Indian Medical Association, Bengal State Branch in 2011. Dr. Janeswar Chakravarti Memorial Oration Award, organized by the Bengal Obstetric and Gynecological Society in 2015. Dr. R.K. Biswas Memorial Oration Award, organized by West Bengal Branch of API in 2016. Let's listen to a Healthy Heart message from Dr. Anjan Lal Datta.
It is the leading cause of death. It is also the leading cause of death in other countries as well, but in most of the Western countries the incidence has come down. But in India it is alarmingly rising. This is even more serious and dangerous than cancer, because death from heart disease is more than that of cancer. Who are the patients likely to get heart attack? This is recognized by 5 important risk factors known as major risk factors. The patient having diabetes, patients having high blood pressure or hypertension, patients smoking, patients having overweight or what is known as obesity, and patients taking diets leading to high cholesterol in the blood are the factors which are responsible for high incidence of heart disease. You can add to that stress, mental stress and strain. But the best way to get rid of this menace is to take care of these 5 risk factors. And another important issue is that you have to report to your doctors as soon as you get the symptoms. But the problem is that most of the Indians think the initial stage that symptoms of chest pain is due to gas and acid. That is a dangerous mistake. Don't ever utter the word gas and acid, because that causes delay in reporting to the hospital, and that delay sometimes becomes very costly. So take care and have good health.
Welcome, sir, to the stage. Today we have a very important question coming to lifestyle changes. Initially we see a lot of people starting actually to do the lifestyle changes, then it's like lasts over 15 days, 1 month, and everything comes back to normal. We give different excuses: Durga Puja, Lakshmi Puja, Saraswati Puja, New Year's. So what can actually be done to make the patient follow the lifestyle changes on a regular basis and on a permanent basis?
There are 2 important issues about lifestyle changes. Firstly, we must understand the importance of lifestyle changes. There is no denying the fact that if you want to bring down the incidence of ischemic heart disease in the society or in the world as a whole or in your family, you got to go by the lifestyle change. And secondly, you have to love the habit. It should not be enforced on you, because if it is enforced on you, as rightly pointed out, you will miss the target. You will just be out of the track. So you have to love the habit, you have to form the habit, and you should feel more confident that you are doing something good for you. And if it is good for you, it is good for your family, it is good for the society. So you should consider yourself as a member of the society and family who likes to stay healthy mentally and physically, and that is the way you can inculcate the habit of good health and good habit to really prevent the disease. Now when you talk in terms of lifestyle changes, as I earlier mentioned, that the incidence of ischemic heart disease is alarmingly high in India, no doubt, much at a younger age. And we have to take care of 5 major important risk factors very seriously. It's also a question of numbers. Like, you take care of diabetes, you must see to it that you check up with your doctors, you have healthy diets in terms of diabetes, you keep your blood sugar controlled, you keep your body weight normal. The second risk factor is obesity or overweight. Now the body weight in Indians are not necessarily very high. Again, the very important way to know what should be my ideal body weight is that suppose your height is 5 feet, which means 60 inches. So your body weight should be 60 kg or less, not 60 kg and above. If you are a 6 feet height man or woman, your body weight should be 72 kg and less. So that is a very simple formula by which you can keep track of your body weight and try to keep entire aspect of your lifestyle changes center around to a large extent on your body weight. Whether you will take excess diet or not, whether you will do exercise or not, whether you will control your alcohol intake or not, whether you will control your diabetes much better than not, will depend to a large extent on your body weight. The second important issue about the body weight in Indian in particular is that you may not have a body weight in general very high. You may have a normal body weight, but your central obesity is high. That means truncal obesity. That means your waist ratio, waist circumference is high. For Indian, the normal figure is about 90 centimeter. Your waist should be less than 90 centimeter for men and less than 80 centimeter for women. So I say that if you want to increase your lifeline, decrease your waistline. That is very important. For at least from the Indian point of view, that is a very important risk factors. Second, of course, the other things are there. You take care of your cholesterol. The figure is very simple. Your LDL cholesterol should be less than 100 if you don't have any heart attack or heart disease. If you have any heart attack or heart disease, your LDL should be less than 70. Take care of your blood pressure. Again, the blood pressure control depends to a large extent on regular medications as well as lifestyle. You have to do regular exercise. You have to do regular meditation if necessary, and most importantly, you have to be in touch with your doctors, because many a times, many patients in terms of hypertension thinks that I am fine, I don't have any problem, why should I carry on the medicines? He stops the medicines and still then he does not feel bad, so he thinks that his blood pressure is normal, but one should forget that blood pressure may rise silently without giving any warning to the patient, and it's rising and rising, and it may suddenly cause very stroke and other important serious complications. So you should know that my blood pressure, whether I am feeling fine or not fine, is not important. It's my job, it's my duty to check my blood pressure time to time, whether I stop the medicine or whether I carry on the medicines. So, and then of course, we have to think in terms of another very major important risk factors in India is smoking. So if you take care of these all 5 factors, diabetes, overweight, hypertension, cholesterol, smoking, and along with that stress factors, then to a large extent you can bring down the incidence, I think, effectively. But at the end of the day, we must remember that lifestyle changes need to be continued, need to be maintained, and you should love it, you should feel good about it.
Regarding exercise, does apps help? Because there are now a lot of apps which count the steps and...
Yeah, at least for the younger generation it does help. But I have found that many of my senior patients are not very familiar with apps, and they feel more confounded and they find it very difficult to follow it. But definitely for younger groups, this is a very important aid to keep them on track and do the job more effectively.
And secondly, in one case we have seen that there was a Singaporean doctor who actually called the patients up in the morning. The patients come and join in the physical activities. Does this sort of things can help in India?
Yeah, because I told you that you should do something about it so that you love it. It should be a social program, it should be a family program, so that you love it and you in fact you look forward to joining it. A sort of ambience should be created like that. And in the like food habit in Indians, we should have more vegetables, more fruits. There are a lot of studies, pure studies and other studies have clearly shown that if you take less carbohydrate, more fruits, more vegetables, you can really prevent the disease significantly. And you should not unnecessarily be worried about eggs and muttons and butters or like this. If your body weight is not very much increased, these things are not to be very much restricted unnecessarily. You just can take a little bit of that, consulting your doctors, but your stress should be in taking less carbohydrate, more fruits and vegetables.
Thank you very much, sir. Thank you, Dr. Datta. So we'll come back to you again in the panel with some more questions.
Okay,
thanks. Next, I would like to introduce somebody who is the President-elect of Cardiology Society of India, one of the renowned cardiologists from across India, national and international repute, Dr. Mrinal Kanti Dash. We would like to see one video about him, what is his message to the audience.
Music is the rhythm of life, and who will understand it better than a cardiologist? Because our heart beats in a rhythm. Introducing a cardiologist, whose mission in life is to alleviate human heart suffering by developing comprehensive understanding of heart diseases for complete relief. Based on his research work, incidentally, one disease in his name called Das and Parua syndrome has been proposed. Meet Dr. Mrinal Kanti Das, a renowned cardiologist from Kolkata, whose melodious whistle we just heard. Currently, Dr. M.K. Das is associated as Senior Interventional and Consultant Cardiologist with B.M. Birla Heart Research Center and Calcutta Medical Research Institute in Kolkata. Dr. M.K. Das is the current President-elect of the Cardiological Society of India. In past, also he had a long stint on serving CSI in various capacities, such as Treasurer, Vice President, Executive Committee Member, etc. Dr. M.K. Das, after his MBBS and MD, did DM in Cardiology from IPG MER Kolkata, post which he earned many prestigious international certifications in the field of cardiology like FICP, FICC and FCSI. Dr. M.K. Das is an extraordinary achiever right from his school time, where he received gold medal from the Chief Minister of Assam in 1972 for securing excellent rank in state examination. During his DM in cardiology, he was awarded with the gold medal for best paper presentation. Dr. M.K. Das' philosophy in life is that a candle loses nothing by lighting another candle. That's why he believes in sharing his knowledge with everyone. He is at present co-editor of the CSI textbook of cardiology, faculty and national expert of the Public Health Foundation of India. He has also worked as the editorial secretary of Indian Heart Journal. While working as honorary general secretary of CSI, he has published a book to raise public awareness about good heart health in India titled 10 Commandments. Subsequently, it was translated in 11 Indian languages. His poem, Give Thy Hands, Give Thy Hearts, was also published in the Indian Heart Journal. Dr. M.K. Das has presented papers at various national and international conferences, and he has written chapters in textbooks of cardiology, textbook of echocardiography, and CSI update books of cardiology, to name a few of them. Dr. M.K. Das was felicitated by the Rotary International Kolkata for his active involvement in benevolent activities on health and education for the needy people. He is also associated with Nishabd Angikar NGO, which was instrumental in building female toilets in Sundarbans in 2012. Let's listen to a healthy heart message from Dr. M.K. Das, the rhythm specialist.
This is my message to all the people, whether they are patients or not patients of cardiovascular disease. We should know that there are two hearts. One heart which is catchable, which you cannot see but we can fathom. And there is another heart that is called the real heart, what we can see and we can feel and we can also touch. The surgeons and physicians, they are doing the things on this particular heart, whether with the medicines or with the scalpels or with any other kind of devices. Now, when I speak about two hearts, the first heart is very, very important because that influences the second heart that is residing in our body. The other heart, which may get depressed, may get elated because of good news or very much welcoming news, that will actually not only enchant the system of our body, but also the whole hormonal milieu in our system. So if your heart is well, if you feel good, if you are happy, then your structural heart also will remain happy. I always quote a poem which has been written by myself. It's a long poem, but I am just mentioning the last two lines. Give thy hands, give thy hearts, to whomsoever. Enjoy the life, enjoy the art, enjoy the heart forever. Now, most of us talk about the risk factors like stress, hypertension, hypercholesterolemia, obesity, diabetes mellitus, smoking, excessive salt intake, lack of physical exercise. So all these are known to most of us. But how we can modulate ourselves to go into the system, that is possible if you have a good mental heart, not the structural heart. If you have that heart, then it will be reflected in your structural heart and you will be having less diseases. Very interestingly, there are few hormones like endorphin, oxytocin. They are also called as happy hormones. Now they get secreted when you are having a good sort of mind And not only that, when you are close to the nature, then they get elevated, and that will be reflected on your brain activities as well as the heart activities. Our poet, Gurudev Rabindranath Tagore, has written a line, "Give me back my forest, give me back my forest, and not the jungle of this concrete." The more we are away from nature, the more we are away from the environment, and more we are sort of averse to the natural processes, that creates or that generates stress inside. And that stress will be reflected in overeating sometime, undereating sometime, and sometime it causes so much so constriction of the vessels or the blood columns that they will increase the blood pressure. And the more we are away from nature, more we'll be having stress generated in our system. And this is mediated by one of the hormones known as adrenaline or catecholamines. Now, very interestingly, these catecholamines can constrict the vessels which carries the blood to the body. Now, these vessels, after being constricted, will generate high blood pressure, and not only that, they will also cause high heart rate problem, and ultimately all the risk factors will be coming into play, causing the coronary artery disease or heart failure or hypertensive heart. All this will be happening because of our going away from nature. Now, I give you one very interesting part of our life, especially for the doctors. Doctors who treat the patients, and they give advice to the patients that you should do this, you should do that. But do you know the doctors, they don't even follow the basic principle of sleep. One must sleep for at least 6 to 7 hours a day, but instead of that, they, or even some other professionals, they are also doing same kind of things. They work for so many hours that they don't follow the usual sleep pattern. Usual sleep pattern, there is a condition called diurnal variation, and there is also a condition called nocturnal dipping of the blood pressure. And this nocturnal dipping of the blood pressure actually helps to a great extent to avoid catastrophe at night. And there is another condition called morning surge. That morning surge of catecholamines and high blood pressure might create some diseases like acute heart attack and all. Now, how can you prevent that? If you just go to the bed early, as is being done by most of the animals and plants on earth, then actually your process of good sleep will happen, and there will not be sleep deprivation, and there will not be any sleep disorder which might be associated with sleep apnea syndrome. And that sleep apnea is responsible for a group of cardiac disorders, not only hypertension but also arrhythmias, then heart blocks, then obesity, then cardiopulmonary dysfunction. And these problems can be averted just by taking a good sleep. So what I am trying to pass to you, that you will be controlling the risk factors definitely, but go beyond that. You can prevent them, prevent hypertension to occur, prevent diabetes to occur, prevent obesity to occur, prevent coronary artery disease to occur in yourself by doing or by carrying out a healthy lifestyle. So that's the message I would like to put to all of you, that you not only give something to the world, but also try to follow the principle of practice before preach. And if you do that, definitely you'll be having a very, very good heart. Thank you.
I would like to welcome Dr. Das to the stage, please. The whistle reminded me of the Raj Kapoor movies for some time. Sir, we would like to ask one important question. Is that when we get the symptoms of heart attack, anybody, people tend to differentiate, people tend to think it as a gastric problem, and they take all the Enos and everything. And then the second time it recurs, they go into a heart attack and then cannot reach the hospital. So how do they differentiate between a gastric problem and a heart attack? What are the things they can do?
This is a very, very important question, as well as a point which should be passed to everyone who are listening to this particular program. Now, heart attack symptoms and gastroenterological symptoms, sometimes they might converge or they might mimic, we call mimic. So, one must be very much aware that if you miss the crucial time, that is the first hour after heart attack, by thinking that my problem is due to gas, then really you are going to have a lot of problems later on in the form of heart failure, in the form of cardiac arrhythmias and all this. Now, classically, the heart attack pain has got few characteristics. Number one, it will persist for some more time, more minutes. It's not like that it comes and goes, comes and goes. It's not like it will be persistent. Second, it will not be related exactly to the exertion. Exertion means you are walking, then you are getting pain. It's not like that. It's persistent even at resting position. Third, it might be located in the retrosternal, that is just in the central part of the chest, but at times the pain may be radiated to the other parts of the body, like it is going to the left side, left arm, or it might even go to the right side of the arm, and very interestingly, the pain even may go up, that is to the jaws. And you might be having a feeling like compressing the jaws. So that feeling is very, very indicative of something related to the heart. Same way, when I am talking about the pain, there are other components which might be associated with it, with the heart attack. So one of the points is the compression, the feeling of compression in the chest. That is a very, very suggestive symptom. Apart from this, if a person is having sort of dizziness or giddiness, it indicates the pressure is falling. And that falling of the pressure, which in our term we call hypotension, that might actually be another indicator. Sometimes even somebody might get suddenly down to the earth because of the hypotension to such a level that brain cannot actually maintain oneself in erect position. And before that or during that time, one might be having the feeling of sinking, as if I am now going beyond this life. So that feeling of sinking is also another feeling or another suggestive symptom of heart attack. Now, when we are correlating with the gastroenterological problem, mostly it comes in the form of pain in the upper part of the abdomen, which is very much confused with the most of the people, because they cannot differentiate. When the patient is coming to us, they are saying, there is some chest pain. Now they are showing it or pointing it to the actually upper part of the abdomen. But in the gastroenterological system, there can be pain on the retrosternal part also, but that will never be associated with some of the features like compressive feeling and all. and that may not be associated with a very grave symptom or even sign that is known as perspiration or sweating. That sweating is a very, very great indicator. Now, apart from this, there might be vomiting along with the, say, upper abdominal pain or chest pain. One might confuse it with the gastroenterological problem, but that will be to the detriment of the, we call it, prognosis of the patient. Because if the person has really a heart attack. Why I am saying this? Because there are different parts of the heart. We call it anterior part, lateral part, inferior part. Now the inferior part is just sitting on the diaphragm, and below the diaphragm the stomach is there. Naturally, the nerves which are taking part in both the stomach as well as the heart, so they will be having common sort of interaction. So a symptom which is produced from the stomach will be reflected there, or vice versa. But you must remember that it will not be associated with sweating, it will not be associated with palpitation, it will not be associated with the coldness of the extremities. So these are some of the features by which one can pick up or one can differentiate. Another point, what you have already mentioned, that by taking the antacids or or like that of kind of medicine, there will not be relief of the chest pain or compressive type of feeling. And that's why I must tell everyone that whenever there is even a pain in the upper part of the abdomen, you must consult the doctor immediately so that the maximum benefit can be offered to that patient who has actually sustained heart attack.
So it is better to give the benefit of doubt and contact the doctor or cardiologist or a hospital A&E immediately. Even if it's in the middle of the night, rush to the hospital, do an ECG and take it from there.
Surely.
Okay. Thank you, sir. Thank you very much. Definitely we'll come back to you again in the panel. Next, I would like to introduce another renowned cardiologist from Calcutta of national and international fame, Dr. Saumitra Ray, who is a consultant interventional cardiologist. We would like to see a short video about him and his message for the audience.
Let's meet a doctor who hails from a family of doctors and for whom excellence is a way of life. He is a perfect amalgamation of professional and personal excellence. Meet Dr. Saumitra Ray, who right from his school days stood first in all his exams, including medical and PG entrance exams. The passion for excellence is in his genes, and this passion made Dr. Ray win over 25 medals during his MBBS. From Calcutta Medical College, followed by many national and international awards. To name a few, our University Gold Medal in MD, Bose Prize in Clinical Medicine, etc. Scholar Dr. Saumitra Ray, with his knowledge, created a distinct mark on his professors during his MRCP and FRCP certification in London and Edinburgh, after which he was offered to work in various prestigious medical institutes of London. To name a few, are Newham General Hospital, London Chest Hospital and Queen Mary's Hospital, etc. But his heart was always beating for India. With this feeling in heart, Dr. Saumitra Ray returned to India and joined Ramakrishna Mission Hospital, where every single day he asked to himself, am I offering the best cardiac care for my patients, or do I need to do something more? This feeling over years led him to form a trust called Calcutta Cardiology Foundation with like-minded colleagues, the first of its kind initiative by a group of cardiologists from Kolkata. And why it's unique? Let's see.
We came to know that you have started a Calcutta Cardiology Foundation.
Yeah.
So what is the basic objective after such a roaring practice? You are getting into social initiatives. So what is working in your mind?
Yes, Shandip. Actually, Calcutta Cardiology Foundation was based on Calcutta Cardiology Club,
Okay.
which we found about 10 years ago, when I found that 6 of us from the same batch of Calcutta Medical College have become cardiologists and are practicing in Kolkata.
Oh.
So we thought, why don't we make it some association? But now after 10 years of this Calcutta Cardiology Club going on, we thought, let's do something more.
Okay.
And that's how we started the Calcutta Cardiology Foundation, which is perhaps the first one of its kind of a trust which is made only by the cardiologist and only to propagate the cardiological awareness of healthy heart awareness towards the community. We are trying to find out, it's a newly grown, a newly made trust. We are trying to find out how most effectively we can do it. We have got various plans. We have already started in a way. Number one, to go to various downtrodden areas of the society, like the red light areas, like the slum areas, like the corporation schools, etc., where we can give them education. We are planning to talk about the head teachers and principals of different schools and colleges to propagate through them the heart healthy living in their school students and college students. As well as we are planning to go to the media for talks and seminars and panel discussion and public awareness camps, etc. More or less also we are trying to educate or enlighten our GPs, general physicians, regarding the modern trend of heart healthy living.
Okay.
Because there are certain myths which are going on, which were taught about 20 years ago in the medical colleges, and those concepts are changing, the parameters are changing.
Correct.
Like a simple blood pressure, what should be the ideal blood pressure, what should be the ideal blood sugar, the blood cholesterol, they are changing.
Okay.
Our targets are shifting.
Right.
So actually the busy practitioners in his own chamber is very difficult for him to cope up with all these new knowledges. So indirectly, if we can train them up to give them in a very nice way and concrete, crispy way what is going on in our field, then they can propagate it and reflect it in their management of the patient, so that we can reach the larger community through them also. So these are the few ideas we have while Calcutta Cardiology Trust we have made. Let's see how we can function.
So you are basically going to educate children, adults working in corporates, and you are also going to train doctors.
Train the doctors.
To
Yes,
take care
yes.
of that. That's such a nice initiative.
Currently, Dr. Saumitra is working as professor in Vivekanand Institute of Medical Sciences, University of Kolkata. He is also working as consultant interventionist in AMRI Hospital, BM Birla Heart Research Center, Woodlands Hospital, Bellevue Hospital, and Shri Aurobindo Seva Kendra Hospital, Kolkata. He is also Fellow of Cardiological Society of India, European Society of Cardiology, American College of Cardiology, and Indian College of Physicians. Dr. Saumitra's commitment to excellence was not limited to himself or for his patients, but he went a step ahead by taking lectures, classes for the PLAB course in UK, and has been part of various teaching as well as training programs for doctors in India and abroad. His articles are published in various national and international journals. Dr. Saumitra Ray has written over 23 chapters in various books of cardiology and has also worked as editor for 6 reputed journals. To name a few are CSI Textbook of Cardiology, The Indian Perspective, Monograph on Heart Failure 2013, and Cardiology Update 2015, etc. In spite of being a busy cardiologist, Dr. Saumitra Ray's commitment for family and friends was never below par excellence. He ensured his best as always. That's why it's apt to say that Dr. Saumitra Ray is a perfect amalgamation of professional as well as personal excellence.
I'd like to welcome Dr. Ray to the stage, please. Please take a seat, sir. So, sir, we have an important question today. In India, we see a lot of patients or people below 40 years having heart attacks. And people are dying. I mean, some people 25, 30 also perishing out of heart attacks. So, why is it that? Is there anything to do with genetics that people in India below 40 are having more of heart attacks?
Very interesting. When somebody's father dies at the age of 40, what does he get? Maybe a house, a car, some bank deposit. But he also gets that package of genes inside him that his time is perhaps again 40 years. Because you'll be surprised to know that a year before last, there was a fantastic publication in European Heart Journal that there are 130 odd genes have been identified which are very strongly associated with heart attack and ischemic heart disease, particularly in young people. Only 6 or 7 of those genes are known to produce some known manifestation, like say sugar, pressure, homocysteine, etc. The others we do not know. So I would say the strongest risk factor of a human being to have a heart disease is his family history. We know that blood pressure is a risk factor, sugar is a risk factor. These are single isolated risk factors. What you have to get as a package of risk factors, almost 90% of are unknown. How they manifest in the body, what to look for, what is the blood parameter. This person is going to have a heart attack. We have got no ideas yet. So genetics is always very important, but you can say, how will you change your genetics? If your father dies at the age of 40, how can you help it? What to do? What you can do is change your lifestyle much more aggressively than your next door neighbor. Because his father has died at the age of 90, yours at the age of 40. So you have to be extra vigilant about what you are doing. And the young people having heart attack, the known things we know is the strongest risk factor is smoking. Of course, blood pressure, sugar, cholesterol, obesity everything are related. All the standard risk factors also are applicable to the people below the age of 40. But the strongest association has been found with smoking. And some other activities like cannabis, ganja and charas. We have seen heart attack people in our institute where we work 20-25 years of age. Most of them are cannabis addict or heavy smokers. Second important thing is there is a condition called familial hypercholesterolemia, homozygous and heterozygous, and there people have very high cholesterol level even from birth or from age 15, 16 depending on your penetration of the genes. And if you have this in your family known or there are physical manifestations of that your doctor can tell you, then you have to be very vigilant and aggressive about your cholesterol management. Females are generally protected by their hormonal status before menopause from heart attack. But after menopause they catch up if not overshoot. But that does not mean that they are away from this smoking habit, cannabis habit, this hypercholesterolemia. From Ramakrishna Mission Hospital, we did a study with a genetic department collaboration to find out the prevalence of methyl tetrahydrofolate gene in our population, which actually reflects in the called homocysteine in our blood. A high level causes heart attack. And that's what we asked to take a lot of fruits and vegetables to keep the homocysteine level down. And to our surprise, we found in this part of the world, around 20% of the people are carrying that bad gene, which expose them to high homocysteine level. So the emphasis which my previous speakers have told about fruits and vegetables are even more in this part of the country because our homocysteine level tend to be high. A recent publication about 6 months ago from north of India showed a very alarming thing. That 25% of our school children from 7th standard to 12th standard are already hypertensive. Can you believe it? 25% of our school children are already having high blood pressure. What is it for? Because of the pressure from the family, from the school, from the society that you have to perform in exam. Recently ICSE, ISC results are out, all the boards are out, 100% is the standard. Why to go beyond it? So for that 100% to achieve, you sacrifice your hobbies, your field activities, the football, cricket, swimming, your recreation, your holidaying with your parents, with your anxiety level keeping down, to go for a healthy meal because it takes time to make a healthy meal. It's much easier to make a chow mein or a burger or Maggie. And you know, the fatter a child, the more acceptable it is to the society. How lovely is your child? He is 20 kg chubby child. So that concept from the beginning, if it goes on, when that chubby child becomes 16, 20 years, he's already having all these risk factors. Pressure, sugar, diabetes, obesity, stress and strain. By the 25 years, if he has got a heart attack, who is to blame for it? He or his society or his parents. This whole outlook needs to change. So I think young heart attack is extremely important in our country, because if you have got a heart attack at the age of 30, 35, there's a prime time of your life. You are building your career, your family is just starting, your family is depending on your earning, and you are losing that capacity for the rest of the life. You are not that active after a heart attack and so on. So I think this is very extremely important to address these issues, not at the age of 40 or 50, but from school children. And we have done projects from our Cardiological Society of India, West Bengal branch, to go to the schools to promote healthy living and to see the effect after a few months. And we saw a very remarkable effect. If we give the education to the parents, to the child carers, to the school teachers, it really reflects in the day-to-day habit of the child. The tiffin box he carries, the amount of time he spends in the field playing football or cricket, that increases remarkably. So I think these are the way forward to prevent heart disease in the young children in India. Particularly if you have got a genetic background, you have to be extra cautious.
In many schools we see over here is they don't have playgrounds also, green playgrounds they don't have.
Absolutely.
So your message is quite clear. You have to take it from the school level, and then only you can prevent something at 40.
To them it's a wastage of time, because they want their children to score more in the board exam so that their school ranks on the top, that my school has got 100% success rate, so many people. So if that is the attitude of the society, it is a sad and sorry state of affairs.
Okay. Thank you, sir. Thank you very much. Definitely we'll take it up more during the panel discussion. Thank you. Okay. Next, I would like to introduce Dr. Suvro Banerjee, who is a interventional cardiologist of international repute. I would like to first start with a small video with his message and his introduction.
Sri Ramakrishna Paramhans has beautifully quoted about love and God when he says that through selfless work, love of God grows in heart. Let's see a journey of a heart doctor who, after obtaining achievements in field of cardiology, is now being part of a trust called Kolkata Cardiology Foundation, which is building a momentum among community for good heart health through various awareness programs. He is also a Paul Harris Fellow and an active Rotarian, contributing to good health initiatives for society. Meet Dr. Suvro Banerjee, a consultant interventional cardiologist for last 15 years. He is currently associated as senior consultant interventional cardiologist with Apollo Gleneagles Hospital, Kolkata. He completed his MBBS from Calcutta Medical College, followed by MD in medicine from SCB Medical College, Cuttack, and MRCP from UK. Dr. Suvro Banerjee is a postgraduate teacher for DNB in cardiology program. He is also an examiner for MRCP UK examinations. Previously, Dr. Suvro Banerjee has been faculty at postgraduate program in IGNOU. His interest lies in research, and he has quite a number of publications under his name in national and international journals of repute. Dr. Suvro Banerjee is also involved in epidemiological studies with University of Calgary, Canada and Warwickshire, UK. Dr. Suvro Banerjee is recipient of numerous awards, and to name a few are academic awards like Certificate of Honours in Physiology 1984, Orfila Silver Medal in Forensic Medicine, professional awards like Barnsley Health Authority Quality Award in 1997, Indian Heart Journal Reader's Choice Award in 2016, Social Award Paul Harris Fellow in 2004, Honorary Professorship conferred by Apollo Hospitals Educational and Research Foundation in 2016. Dr. Suvro Banerjee's special area of interest is in heart failure and was also joint convener for the National CSI Guideline Committee position paper on heart failure, and has contributed to the development of the guideline, which was published in the Indian Heart Journal in 2018. Let's listen to Dr. Suvro Banerjee's tips for a healthy heart.
My message to viewers is that you could largely prevent having heart disease by following some simple rules. I would advise you to have a balanced diet, avoid excess sugar and sweets, avoid fried foods, oils, and processed food, including processed meat. It's important that you do exercise regularly, and walking is a good form of exercise, irrespective of your age. You should give up bad habits such as smoking and cut down on alcohol. It's also important not to get stressed, but as you know, stress is present in every corner of life. It's not that easy to avoid stress altogether, but what is more important is to change your attitude towards stress. You should take stress boldly, with courage, and should not get bogged down with stress. It should be more of a challenge to you. This reason is, it's been seen that the way stress affects your heart is different for different people. And experiments have shown that if you give 3 different people same amount of stress, they would react differently. Some would take it as a challenge, boldly, and then good hormones would be released in their blood. And those who get really afraid of the stress, who break down under stress, bad hormones are released in their body, which increase their heart rate, which increase their blood pressure, which increase the thickening of the blood inside the arteries and can cause them heart attack. So it's more important. The stress itself cannot be that important. It's more important how you respond to stress. So if you respond to stress in a favorable way, then you would do better. On the other hand, if you respond to stress in a way in which you shouldn't, then your heart may be affected adversely. This is a message I would like to get through to you. Also, if you have other risk factors for heart disease, such as high blood pressure, blood sugar, or cholesterol, then it's important that you keep these under control. And also, I think it's important to get yourself checked at least once a year to make sure that things are in order.
Dr. Banerjee has been my teacher during the PLAB, so we have a lot of learnings from him I have received in my life. Today's question we would like to know is that once a patient is having a heart attack, what can immediately be done to save the life of the patient? This is the first part. And the second part is that, are the modern medicines good enough to prevent a heart attack?
Okay. Let me answer your first question first. I think, patients wouldn't know that they are having a heart attack. What they would have is a chest pain. And as you know, chest pain is one of the main symptoms of heart attack. But there are other causes for chest pain as well. And heart attack is perhaps one of the more dangerous ones. So if you are having a chest pain, then possibly you may be having a heart attack. And if you're having a heart attack, then the best place where you could be is in a hospital. So the guideline says that if you're having a chest pain and it doesn't go off within 15 to 20 minutes, then you call an ambulance and go to the nearest hospital which would have the infrastructure to deal with a patient with heart attack. You may inform your doctor, local doctor, but you do not really wait for him to come to your home to see you. Now, once you are in the hospital, you'd be seen, assessed by a doctor. They will do an ECG and blood tests, and if they think that yes, this is a heart attack, then your the blocked artery which has caused the heart attack would need to be opened up. And this could be done in 2 ways. The superior way would be to go ahead, do an angiography, locate where the blockage is, and then do an angioplasty to open up the artery. But sometimes what may happen is that you may be in a remote place where you may not have an access to a tertiary hospital capable of doing this. And then you still go to a local nursing home or a hospital where they can at least give you a medicine to dissolve the blood clot. And after that, you could be transferred to a bigger hospital, a tertiary hospital, to go to further angiography and angioplasty if still necessary. This is very important, but again, I would say, now, what are you going to do while you're waiting for the ambulance to come? Now, here I would say, make the victim, just lie comfortably, loosen his clothes. You may turn, if he's a bit obtunded, then you may actually turn his head to a side so that if he's vomiting, he doesn't aspirate that vomitus. And then otherwise, if you think this, if he thinks that if he doesn't have any history of, say, ulcer in the stomach, if he has never bled from his gut, then probably you can give him a dose of aspirin. You can ask him to chew 300 milligrams of aspirin, and that could be a real saver. If he had previous history of angina and he has a nitrate spray or nitrate tablet, then he can also use it a couple of times to see if that eases of his pain. But the message which I would like to get through is the best thing for him would be to be in a hospital as soon as possible, so that the primary the things that need to be done to open up the artery is done without delay. Because this is a condition where we say time is muscle. As opposed to time is money, this is time is muscle. So if you really lose a lot of time in getting the patient the definitive treatment, then more of the heart muscle would be lost, and they may not be able to. You may not be able to get back later, and then even if you live, you may live with disability. And to answer your second question, I think it was like, what if, whether the medicines that are available now are able to prevent heart attack? Well, I would say yes, there are medicines, like as I've said, aspirin and statin, who are there, who would be able to reduce the chances of having a heart attack, but they won't be able to totally prevent you from getting a heart attack. And one must realize that these medicines are not to be taken by everyone. There are certain indications. If you have the risk factors, certain risk factors, then you may actually benefit from these medications. But I would like to stress that to prevent a heart attack, most important would be your lifestyle modification. And if you can't really change your lifestyle modification and change your lifestyle, then just by taking medications, I don't think you are really going to prevent yourself from getting a heart attack.
So both are important. Lifestyle changes plus the medicines.
Especially the lifestyle changes first, but to prevent the heart attack, if it's different from if you already had a heart attack, then medicines become very important. But to prevent a heart attack from happening, I think lifestyle modifications are more important than taking pills.
Okay. Thank you very much, Dr. Banerjee. Definitely we'll come back to you again in the panel. Thanks very much. Good evening, everybody. Welcome back to the second part of Dil Se Dil Tak. Now we are going to have another 45 minutes of very stimulating panel discussion. The first question for the panel discussion is Dr. P.K. Deb. Sir, the question is that when the patients are suspected to have a heart attack, or somebody is at the propensity of or the high risk of a heart attack in the community, is there some non-interventional ways like CT angio or stress test or calcium scoring which actually can be done to actually preempt the condition?
That means you want to know how to precipitate out the person who will get heart attack by these methods.
Yes.
Look, experimentally the answer is yes. But in the practical field, in a country like India, where the logistics are very poor, some people have too much money with no available infrastructure. Some people may reach to the available infrastructures, and most of the people going to the government hospitals where there is practically not adequate infrastructure. So in this situation, I will advocate that we should go by clinical medicine at first. Clinical medicine means that I will take the history properly. I do it in practice myself. Family history. Do you have any heart attack in your family or not? In your first order relatives, second order relatives, Do you have any incidence of heart attack in young age in your family or not? Is there anybody who is suffering from diabetes, hypertension, central obesity, metabolic syndrome like associations? These are there in your family or not? And whether if there is any clustering of risk factors in that particular individual, and more so if there is any suggestive symptom. Heart attack may come in patients who do not have any symptom at all. Heart attack, it comes mostly in patients who have some symptoms. Symptoms means if there is angina, classical angina. If the patient has classical angina, and if the patient has some patterns in the angina, recent severe angina, recent acceleration of the angina pattern, angina during rest, I know that these are the persons who may pass on to heart attack, or STEMI, or non-STEMI, or severe form of unstable angina very quickly. These are the situations I may like to understand. I go to some investigations. ECG first. ECG gives some idea, but it doesn't help them to localize the area, localize the artery which is diseased, or how many areas in that particular artery there is blocks, whether the blocks are critical or not. So ECG first, but still with the symptoms and with the ECG patterns, ECG may be normal in patients with severe disease, but it gives us some idea. If the symptoms are severe, and I'm sure that if the patient has a bad family history, I may go for invasive coronary angiography. Or if the symptoms are less severe, there is clustering of risk factors, I will have to decide whether I will go for stress ECG or not. For stress ECG, it is very informative, but unfortunately it is not practiced so much. If we do it carefully, but not doing stress ECG with patients with unstable symptoms, in patients with failing heart failure symptoms, or patients with precipitating critical arrhythmias, if we select the cases properly, I think the stress ECG gives us wonderful results. It gives us some qualitative and also quantitative assessment. We can do some stress echo, it may be stress cardiac MRI, it may be stress scintigraphy, but these are all theoretical discussions. I will go for, if it is possible, I will go for stress ECG, and if the stress ECG gives me that it is positive in low workload, I will go for coronary angiography, because this is the patient who will pass on to unstable symptoms very soon. But other areas, say the stress echo, the stress coronary angiography, stress scintigraphy, I think these are more theoretical, less of any practical utility. Consider the symptoms, consider the stress factor clustering, consider the genetic pattern, and proceed accordingly. Apply your knowledge on the particular patient.
Especially in preventive, it is quite common in the corporate sector that they do a preventive health checkup every year, and they spend quite a lot of money on it, and they do all the stress tests on it. So there is no rationale of adding a calcium score to it to actually look into the arteries.
Look, coronary calcium score, if it is done, yes, it gives us some idea regarding it is another risk factor, maybe a more dominant pattern, potent risk, but it doesn't give us we cannot apply this for the mass. For the general population, it is not applicable. Okay. Logistically not applicable for the mass general population.
Okay. Thank you very much, sir. Next question is for Dr. Dutta. There is a myth that is seen among the patients that whenever a person is sent for angiography, angioplasty is also done with it. So is it that, what is the truth? Is it angiography only procedure only can be done, or it has to be followed by a angioplasty in the same setup?
Yeah, definitely it's a wrong concept. I won't use the word myth, it's a wrong concept, because angiography is a test, it's a diagnostic procedure by which you identify if there is any disease in the coronary artery or not. You image the coronary artery, তার মধ্যে কোনো ব্লক আছে কিনা, ব্লাড সাপ্লাই আটকাচ্ছে কিনা, তার জন্য পেশেন্টের কোনো ক্ষতি হচ্ছে কিনা, it's a test. And angioplasty is a therapeutic procedure, is a form of treatment by which you remove the block by putting a stent and what is known as balloon angioplasty. You do the ballooning first, then stenting, or you can go for direct stenting, whatever may be. You ultimately remove the block so that blood supply is restored and the muscle is retrieved. একটা হচ্ছে ট্রিটমেন্ট angioplasty আর একটা হচ্ছে টেস্ট, সেটা হচ্ছে angiography. Now there are certain situations in heart attack which in medical parlance we call it STEMI, ST elevation myocardial infarction, where the large amount of myocardium or a small amount of myocardium, whatever be it, myocardium is in jeopardy because of lack of blood supply. As early as you restore the blood supply, you retrieve the muscle. So salvaging myocardium becomes the most important part of treatment. So you have to open up the coronary arteries as early as possible. So if a patient comes with acute myocardial infarction or STEMI and you are going to do a coronary angiography, in all likelihood, 99% chance, you will get a blockage there. সুতরাং বাড়ির লোককে বলতে হবে যে আমার যেহেতু একটা হার্ট অ্যাটাক হয়ে গেছে ওনার, I am going to do an angiography. That angiography is probably will be a blockage there, and I have to do the necessary steps of treatment to remove the blockage so that the blood supply is restored and the patient's heart muscle is retrieved, and that would be the best treatment at this stage for the patient. এবং এটা বলে I should go for angiography and be prepared to do the angioplasty. So that is the situation where angiography is usually followed by angioplasty. There may be another situations where it is not as much as urgent, where the patient may have an acute chest pain, what is known as unstable angina, but may not have exactly the heart attack. But likelihood is that this patient, if continues like this, he may have an heart attack soon. So shekhanao there is urgency that you do an angiography, and if necessary, if there is a blockage is there, it would be better to do the angioplasty at that stage rather than doing it at a later stage. But then that is not as much a must as it is in acute myocardial infarction of what is known as STEMI type. Third group of patient যেটা আমাদের আসে, অর্থাৎ in other words যদি ইসকেমিক হার্ট ডিজিজকে আমি ভাগ করি তিনটা গ্রুপে, একটা হচ্ছে হার্ট অ্যাটাকের পেশেন্ট, আর একটা হচ্ছে হার্ট অ্যাটাক হয়নি, তার একটু হাঁটতে চলতে গেলে ব্যথা হচ্ছে. You are getting chest pain while you are undertaking physical activity, you are getting discomfort while you are undertaking some mental stress or strain, and it subsides as when you are mentally relaxed or when you are taking physical rest. So that type of angina, that type of chest pain is known as chronic stable angina. So when you have a patient of chronic stable angina, you are doing coronary angiography for two purposes. One, to confirm that it is ischemic heart disease and the angina is due to blockage of a coronary artery. First, and second is to see to what extent the blockage is there. Whether the treatment would be only medical, whether the treatment would be surgical, or whether the treatment would be angioplasty or stenting. So I do angiography in chronic stable angina. For that matter, আমি কেন সবাই পৃথিবীর সবাই তাই করে. But I do angiography at this stage of patients or this type of patients for two purposes. One, to confirm the diagnosis, and then to decide about what type of treatment would be the best for him. শুধু মেডিকেল ট্রিটমেন্ট হবে না অ্যাঞ্জিওগ্রাফি করে অ্যাঞ্জিওপ্লাস্টি করতে হবে নাকি বাইপাস সার্জারি করতে হবে. কিন্তু এই অ্যাঞ্জিওপ্লাস্টি or bypass surgery or whatever it is not a necessity at that stage, because the patient is otherwise normal at rest. He gets discomfort only while undertaking physical activity. So if I do an angiography and if I find that the patient is amenable to medical treatment, though there is a blockage there and does not require angioplasty, then he will be on medical treatment. If I do an angiography and find there is a blockage, he requires an angioplasty, I will ask the party, patient, that আপনার একটা angioplasty দরকার আছে, আপনি এটা এখনো করতে পারেন, পরেও করতে পারেন, তাড়াহুড়ো কিছু নেই যে আজকেই করতে হবে. So they can take their time, they can find out the suitable time, come back for angioplasty after some time, after some medications also. অথবা যদি বাইপাস সার্জারি হয় একই কথা, যে আপনার বাইপাস সার্জারি দরকার আছে, আপনি করতে পারেন. এর বাইরে there may be a fourth group যেখানে ইমিডিয়েট অ্যাঞ্জিওপ্লাস্টির দরকার হতে পারে. সেটা হচ্ছে পেশেন্টের হার্ট অ্যাটাক হয়নি, বুকে ব্যথা হয়েছে, কিন্তু আর্টারি ব্লকেজটা এত ক্রিটিক্যাল, it is almost 99% and you are afraid that it might just lead to total occlusion very soon. সেখানে ওদের বলে দেওয়া, সেখানে কিন্তু একই সিটিংয়ে করতে হবে এমন কোনো কথা নেই, বাট ইটস বেটার টু গেট ইট ডান, বিকজ মেনি টাইমস ওয়েন ইউ অ্যাডভাইস দেম দে কাম ব্যাক আফটার সামটাইমস at a suitable time. It is not a must that we should do it at this stage. We find that many of the patients don't come back, and ultimately they'll end up with trouble because the patient may develop a heart attack in a couple of days' time after discharge from the hospital. সেখানে এটা বলে রাখা ভালো যে আপনার ইমিডিয়েটলি দরকার, আপনি এখনও করতে পারেন, পরেও করতে পারেন। এই 4-5টা ভাগের স্টেজে আমরা বিভিন্নভাবে জিনিসটাকে বিচার করব।
Thank you very much, Dr. Datta. Next question is for Dr. Das. Dr. Das, we would like to know how you differentiate and decide that this patient needs angioplasty and this patient, the other group of patients, need a CABG or a bypass surgery. How do you differentiate between the two?
This is another important question actually, which is faced by all of us, by all the patients who are having heart disease. Now, heart disease with coronary artery block. Now, one must know that there are actually, I'm showing this, so there are actually 3 coronary arteries. On the left side, there are 2, and on the right side, there is 1. Now, apart from this, there may be so many other branches of the artery, coronary arteries, which are named differently. Now, based on the number of arteries involved, the decision regarding the angioplasty or PTCA, we call it, or CABG are decided. Now, basically, when there are 1, 2, or 3 arteries which are at accessible place, then they are good candidates for angioplasty. Again, if these 3 arteries are blocked, but the person is having diabetes mellitus, then in that case, we have found that the stenting which is done is a ring which is put inside the blocked artery after it is inflated with the balloon. So the results of the angioplasty in coronary artery block, multiple coronary artery blocks with diabetes mellitus is not that good. So that will be a candidate for actually coronary bypass graft. Now, many a time what happens, the arteries may be blocked in such a way, or there might be 1 or 2 arteries which are totally blocked. They may not be opened up by the usual process of angioplasty. In that case, if it is associated with another artery which can be opened up, but we usually don't go for the angioplasty in those kind of cases also, and we straightway advise the patients to go for the coronary artery bypass graft. So, according to the severity of the illness or severity of the coronary artery involvement, we advise whether the person will be benefited with the coronary angioplasty or by the CABG. There is another group where there are multiple coronary arteries involvement are there and associated with heart failure. Heart failure is the failure in the part of the heart to pump adequately. Now, that pumping failure is likely to have more sort of mortality. Now, if that patient is to be benefited, one can go for the angioplasty if the person actually denies the benefit of CABG. Otherwise, they are also good candidates for coronary artery bypass graft. And of course, when a critical block is there and the angioplasty has picked up that block and there might be imminent danger, automatically we don't waste time. We straightway go for the angioplasty rather than the CABG. Another group might surface during the time of angioplasty. The angioplasty patients is having some complications. Complications in the form of rupture of the coronary artery or severe sort of arrhythmias or like that. In those cases actually, many a time, we take the help of the cardiac surgeons, and they might go for a bailout surgery. That has happened, I think, in most of the cardiologists' life. So bailout surgery is also done. So The crux of the problem is severity of the illness, number of arteries, and associated with any other diseases. These all will determine whether I'll be choosing the angioplasty or the bypass surgery.
Okay, and so before even deciding, so you discuss everything with the patients and the relatives?
That's a must. In fact, before any procedure, one must explain the patient what I am going to do. Say, for example, the angioplasty. I can do the angioplasty both by the radial artery in the upper arm or by the femoral artery in the lower limb. Now, I must explain what are the pros and cons of these procedures. I must explain. I always take that time to explain the relatives as well as the patient that whether you are comfortable with the test or not, because it has got certain risk of the complications. Now, same way with the angioplasty procedure or with the bypass also, the explanation is a must, both from information point of view and also from legal point of view. And after only they have given the signature that yes, I have understood the methodology and the procedures, then only we subject the patient for angiography, angioplasty, or even the surgery.
Thank you very much, Dr. Das, for your insights. The next question is for Dr. Ray. First, we would like to know from you that after the angioplasty and the bypass, when can the patient return to work? Number one. Number two question is that we have seen in some of the cases that doctors are urging the CBG patients to even start exercise within the 5 days, in hospitals also to run on the treadmill, take light weights and exercise. So how far is it compatible with the patient's condition, and how do you decide on these things?
There are two aspects of it. First is why the angioplasty or bypass was done, whether it is after a heart attack or as a planned procedure. That is number one. And number two, what is the pumping function of the heart remaining? What we called in our terms ejection fraction. If the ejection fraction is normal, even after a heart attack, angioplasty, bypass, then you are much more liberal. We are much more liberal to allow the patient to go back to normal life earlier. সত্যি কথা বলতে অ্যাঞ্জিওপ্লাস্টির পরে দুদিনের মধ্যে patient can go back to normal life, provided he is not after a heart attack, his ejection fraction is normal. প্রশ্নটা হচ্ছে যে কি কাজ তিনি করেন এবং কবে থেকে সেটা শুরু করবেন, যেটা আপনি জিজ্ঞেস করলেন। ধরুন একজন স্টেশনের কুলি যাকে 50 কেজি করে মাল তুলতে হয়, আর একজন অফিসের ক্লার্ক যিনি ঠান্ডা ঘরে বসে লেখালেখি করেন, অথবা সেই অফিসেরই যিনি হেড বস, যিনিও ঠান্ডা ঘরে বসে থাকেন কিন্তু প্রচুর স্ট্রেস নিতে হয়। তো তিনটেই কাজ তো কোন কাজে কবে ফিরতে পারবেন? যেটা ফিজিক্যালি ডিমান্ডিং কাজ বা ভেরি মাচ স্ট্রেসফুল জব, then you have to take your time. Usually we say after a heart attack, whatever be the procedure, whether you treat medically or angioplasty, you take 2 to 4 weeks for the heart muscles to heal. Because there is a damage, there is some death of some cells in the tissues in the heart. So give the natural course of healing time to that tissue, which is usually 2 to 4 weeks. So 2 to 4 weeks, you can start small activities in the house, maybe an evening stroll, maybe socializing, going to your relative's house and so on. Angioplasty per se does not change your scenario. I have seen patients going back in UK, going back to house after angioplasty, driving themselves after a couple of days. So angioplasty doesn't make any difference. Bypass, of course, is a big undertaking. আপনি হাসপাতালে থাকছেন 7 to 8 days. There are a lot of wounds in your body. Your sternum is open and sewed. There may be wounds in your hands, in your legs. So they take normal course of about a month or so to heal up completely. If you put unnecessary stress and strain on those healing tissues, there will be impaired wound healing, chance of infection, and so on. Number two is the first question people ask, je khana kya dur daktar sahab? It's a very dangerous question. I mean, ucche khaben na potol khaben, eigulo to answer dewa jay na. So প্রশ্ন হচ্ছে, this is an opportunity to go back what happened before the heart attack. কেন হার্ট অ্যাটাকটা হলো, হোয়াট ওয়াজ হিজ প্রেশার, সুগার, কোলেস্টেরল, লাইফস্টাইল প্যাটার্ন, স্ট্রেস অ্যান্ড স্ট্রেন, ওবেসিটি, সেইগুলো অ্যাড্রেস করা দিস এ বিগ টাইম অ্যান্ড দ্য পেশেন্ট ইজ মোর অ্যাকসেপ্টেবল বিকজ হি হ্যাজ হ্যাড দ্য এক্সপিরিয়েন্স অফ এ হার্ট অ্যাটাক, সো দে উইল অ্যাকসেপ্ট ইউর অ্যাডভাইস মাচ মোর। সো দিস ইজ ভেরি ইম্পর্টেন্ট। সেকেন্ড হচ্ছে কার্ডিয়াক রিহ্যাবিলিটেশন ইউনিট, যেটা অনেক দেশে আছে, আমাদের দেশে খুব কম আছে। সেখানে গ্রেডের এক্সারসাইজ করে করে দেখা হয় যে আপনি কতটা নিতে পারছেন। প্রথমে একটু বল ববিং করলেন, তারপর একটু হালকা ট্রেডমিল করলেন, কতটা মেটস আপনি অ্যাচিভ করতে পারছেন, আপনার পালস, ব্লাড প্রেশার কীরকম বিহেভ করছে, আপনার কোনো অ্যাডভার্স সিমটমস হচ্ছে কিনা, তার উপরে নির্ভর করবে আপনি কতটা কাজে ফিরবেন, সুইমিং করবেন কিনা, ড্রাইভিং করবেন কিনা, আপনার আর কোনো হবিস থাকলে করবেন কিনা, পিপল আস্ক অ্যাবাউট সেক্স লাইফ, এভরিথিং ডিপেন্ডস অন হাউ মাচ স্ট্রেস অ্যান্ড স্ট্রেন ইউ ক্যান টেক। তবে আমার মনে হয় 7-10 দিনের আগে কোনোটাই বেশি করা উচিত নয়। আফটার এ কাপল অফ উইকস ইউ স্টার্ট ডুইং দ্য থিংস গ্র্যাজুয়ালি। রুল অফ থাম শুড বি ইউর বডি উইল টেল ইউ হোয়াট টু ডু। হিরোইজম করার জায়গা কিন্তু আর নেই, মানে ইউ ডোন্ট হ্যাভ টু প্রুভ ইউর সেলফ, ইউ হ্যাভ প্রুভড ইউর সেলফ অলরেডি হ্যাভিং এ হার্ট অ্যাটাক, ইউ আর অলরেডি এ হিরো। আপনার স্টেন্ট লেগেছে, আপনার বাইপাস হয়েছে, আপনি আপনার কলিগদের কাছে খুব ঈর্ষণীয় যে আপনার এত কিছু হয়ে গেছে, আর নতুন করে প্রমাণ করার কিছু নেই আপনার। এই যে আপনার যদি মনে হয় দোতলা উঠতে গিয়ে আপনি হাঁপাচ্ছেন, তাহলে উঠবেন না। আপনার প্রমাণ করার দরকার নেই আপনার ওয়াইফের কাছে যে আমি দেখো পুরো সুস্থ হয়ে গেছি, দোতলা উঠতে পারছি। ইউ টেক ইউর টাইম, you give your body for the natural healing course, which will vary from person to person, and listen to what your body is telling you. সেটা আপনার সিঁড়ি ওঠাই হোক, আপনার অ্যাক্টিভিটি হোক, আপনার রিক্রিয়েশনই হোক, বা আপনার অফিসে জয়েন করাই হোক। জেনারেলি আমরা একটা বাইপাসের পরে 1 থেকে 1.5 মাসের মধ্যে সার্টিফাই করি জবে ফেরার জন্যে। অ্যানজিওপ্লাস্টির পরে তো আমি স্ট্রেট ওয়ে 7 দিনের মধ্যেই করতে বলি। হার্ট অ্যাটাক যদি হয়ে থাকে, whatever else has been done, it takes its time about a month or so to go back to normal life.
অকুপেশনাল থেরাপিস্টের যে রোলটা রয়েছে ওয়েস্টার্ন কান্ট্রিজে, আমাদের ইন্ডিয়াতে দেখি সেই রোলটা আছে?
সেই রোলটা ভীষণভাবে আছে, থাকা উচিত, কিন্তু এগেইন যেটা সবাই বলছেন যে আমাদের ইনফ্রাস্ট্রাকচারের এত অভাব যে তার জন্য তো পয়সা লাগবে। আপনি একটা জায়গায় 15 দিনের একটা কোর্সে ভর্তি হবেন, তারা আপনার পেছনে 4-5 ঘন্টা ব্যয় করবে এভরিডে, সো দ্যাট টেক্স রিসোর্সেস অ্যান্ড মানি। If you can afford it, if you can find a center, it is extremely good. You become confident, you get the health tips, what you should eat, what you should do, do's and don'ts, smoking counseling, alcohol counseling, everything is important. That is part of that rehabilitation center. And of course they will tell you, now you can go back to your swimming pool, now you can go to your sex life, now you can drive your car, now you can drive a public vehicle, and so on and so forth. তো সেটা তো খুব এক্সট্রিমলি ইম্পর্টেন্ট রোল আছে, কিন্তু কলকাতা শহরে আমি খুব একটা বেশি দেখি না। নিশ্চয়ই আছে, কোনো কোনো হসপিটালস চালু করেছেন, এটা আরও বেশি হলে কিন্তু আমাদের রোগীদের জন্য সুবিধা হবে।
Thank you very much, Dr. Ray, for your inputs. Next question is for Dr. Banerjee. So, regarding heart problems or heart diseases, there are some other comorbidities which are there. Like hypertension, as you said, dyslipidemia is there, then kidney disease is there. So what is their exact role in the treatment of heart diseases? And if there is a, like suppose a kidney disease, chronic kidney disease and a heart attack, heart disease, how does it complicate the situation?
Yeah, that's a good question. প্রথমে দেখা যাক এই যে কথাটা কোমরবিডিটি, সেটার মানে হচ্ছে যে অ্যাসোসিয়েটেড ইলনেসেস একজনের লোকের আছে which make him more prone to develop a heart attack or it affects the prognosis of the heart attack. এগুলো যেমন বললেন কিছু যেগুলো আমরা জানি, যেমন ডায়াবেটিস, ব্লাড প্রেশার, যদি কোলেস্টেরল ব্লাডে বেশি থাকে। আরও কিছু আছে যেগুলো লোকেরা অতটা জানে না, যেটা আপনি বললেন, যেমন যদি তাদের ক্রনিক কিডনি ডিজিজ থাকে, তাদের যদি এট্রিয়াল ফিব্রিলেশন বলে একটা জিনিস থাকে যেটা ইরেগুলার হার্ট রেট, বা তাদের যদি স্লিপ অ্যাপনিয়া বলে একটা জিনিস থাকে যেখানে হচ্ছে তাদের দেখা যায় যে রাত্রিবেলায় ঘুমটা ভালো হয় না, তার সাধারণত নাক ডাকে, দিনের বেলা একটা ঘুম ঘুম ভাব হয়, এদের দেখা গেছে যে হার্টের উপর এগুলো এফেক্ট করে। এখন এতে কয়েকটা প্রবলেম এতে দেখা যায়, যেমন কি যেমন ডায়াবেটিস যদি কারো থাকে, দেখা গেছে তাদের মানে হার্টের যে করোনারি আর্টারি ডিজিজ যখন আমরা অ্যাঞ্জিওগ্রাফি করি দেখা যায় দে আর মোর ডিফিউজ, অনেক কটা আর্টারি ইনভলভড হয়েছে, আর্টারিগুলো খুব ডিফিউজলি ইনভলভড হয়েছে। দেখা যায় যে তাদের মানে আর্টারিগুলো অনেক সময় ক্যালসিফাইড থাকে, যার ফলে কি হয়, এক নম্বর হচ্ছে এদের যখন আমরা অ্যাঞ্জিওপ্লাস্টি করি তাদের অনেক সময় দেখা যায় যে প্রসিডিওরের কমপ্লিকেশন রেটটা বেড়ে যায়। আরেকটা জিনিস মনে রাখতে হবে, ডায়াবেটিক পেশেন্টরা অনেক সময় তাদের কিন্তু বুকে ব্যথা, যেটা মেইন সিমটম অফ হার্ট অ্যাটাক, সেটা অনেক সময় হয় না, এবং তাদের সেই জায়গায় হয়তো একটা শ্বাসকষ্ট হলো, যার ফলে অনেক সময় ঠিকমতো ডায়াগনোসিস হয় না বা পেশেন্ট অনেক সময় লেট প্রেজেন্ট করে। তো এইগুলো ডায়াবেটিক পেশেন্টদের বেলায় আমাদের খেয়াল রাখতে হবে। তেমনি যাদের দেখা যাচ্ছে কিডনি প্রবলেম যাদের আছে তাদেরও দেখা গেছে যে অনেক ডিফিউজ করোনারি আর্টারি ইনভলভমেন্ট হয়, এবং তাদের অনেক সময় আমাদের যে প্রবলেমটা দেখা যায় যে অ্যাঞ্জিওগ্রাফি করে যে ডায়াগনোসিস করব তাদের ক্রিয়েটিনটা যদি বেশি থাকে সেই রকম ডাই দিয়ে আমরা যে পরীক্ষাটা করি সেটা করা যায় না, কারণ তাতে কিডনি ফেলিয়ারে চলে যাওয়ার একটা চান্স থাকে বা ক্রিয়েটিন বেড়ে যাওয়ার চান্স থাকে। তখন খুব দরকার হলে আমরা কিছু প্রিকশনস নিয়ে করি, কিন্তু তবুও একটা রিস্ক থেকে যায়। তেমনি এদের বাইপাসের রিস্কও বেড়ে যায়। এই জিনিসগুলো যেমন কারোর যদি ক্রনিক অবস্ট্রাকটিভ এয়ারওয়ে ডিজিজ থাকে, যেমন সিওপিডি থাকে, তাদেরও বাইপাসের করার সময় কিছু প্রবলেমস হতে পারে। অতএব কোমরবিডিটিস যেগুলো আছে সেগুলো এক পেশেন্টের ডিজিজের আউটকাম সেটাকে এফেক্ট করে, তাদের ডায়াগনোসিসে প্রবলেম করতে পারে, তাদের কি ধরনের ট্রিটমেন্ট দেওয়া বেটার হবে সেই জিনিসটা ডিসিশন মেকিংয়ে এটা ভীষণ ইম্পর্টেন্ট হয়ে যায়। তো এই সব জিনিসগুলো আমাদের তখন মনে রাখতে হয়।
Regarding heart disease or heart attack, ischemic heart disease, is there a gender bias?
Yes, of course there is gender bias. Actually, we all know that patients with rather female patients are more protected than male patients from having heart attack, but this is only true till the age of menopause. And this is because of the protective effect of the hormones that the females have till the age of menopause. But after the menopause, this difference is lost. And then the females are probably as sort of prone to develop heart attack as the male. But here's something I would like to say, that females who smoke, who have high blood pressure, who have diabetes, they may not have this protective effect of their hormones. And in that case, this preferential sort of, I would say, the risk of females over the males is lost.
Okay, thank you very much, Dr. Banerjee. We are getting some questions through the live interaction on the Facebook, and there's one question which is there. I would like to ask Dr. Deb this question. What tips should you like to take care of your heart while at work? Because I think the question has come because increasingly at work we are sedentary, we are sitting in a chair. We don't have any other option. With 9 hours, 10 hours at work or 12 hours for IT people, this is very common. Yes. So what can we do at work at least to be more mobile or taking any precaution, I would say?
Can you repeat the question? I couldn't get it.
Yeah. So what tips should you give to take care of your heart while at work?
That while at work means, look, we always work. In fact, it is the Japanese dictum is that while at work, don't use the lift, use the staircases.
Yes.
So if you want to go for tiffin, to take tiffin outside, you walk.
Yes.
So it is called on-the-job walking or on-the-job activities. If you do regular on-the-job activities, in fact, early morning walking is not necessary at all. So in fact, one of the reasons that the women in India, they get less incidences of heart attack is that they're always involved on the job activities within the house. For household activities from the morning till night, they're on the job activities. So they don't need any further prescription for early morning walking for 20 minutes, 30 minutes a day for 4 to 5 days a week. They're not necessary. But otherwise, the problem is the high-collar jobs who go to the office by car, they use the lift. They don't go to any place. So they should be encouraged to take on-the-job activities, to walk inside the office. Other than asking for the file to come, you go to the person to take the file. You walk in the, you go to the remotest toilet in the office. You use the stairs. So these are the things that should be advocated in the office and also in the houses, because this is more rampant in retired life. So in retired life we should be on the activities not by using the mechanical helps, using the going to the remotest place. I advise my patients, if you don't find time to walk, and while you come back, even by car or by public transport, just stop one stoppage ahead, or 1 or 2 kilometers ahead. Walk the distance. In fact, it works. It works wonders.
Especially I have heard one MD of a company saying that he generally does, he was an Abbott MD, so he says that I take the meetings in a standing position. So the meetings, number one is that people burn the calories while they are doing the meetings, and the meetings are running shorter because of shorter duration. Because what happens is the meeting, people tends to continue in a sitting position and the discussion continues for a longer period of time, which is actually adding up to the sedentary lifestyle more. So this is one way which can be used as well. There is another question which has come. I would like to ask Dr. Dutta this question. If a stent is placed in an artery, for how long should I take antiplatelet medication?
This is a very important dynamic question. The stents that we are using now is of a much better quality than the stents that we used to place earlier. And these all stents are what is known as drug-coated stent or drug-eluting stents. Usually the antiplatelet agents that we use are of two types. One is aspirin, which is common. Another is one of the three. The three are clopidogrel, ticagrelor or prasugrel. I'm not going into details as to who should get what, but all of them receive aspirin, and in addition to that one more of the three. এখন প্রশ্নটা হচ্ছে যে how long should we continue with these antiplatelet agents? Now normally if you don't have any side effects, if you don't have any bleeding tendency, we should consider for all practical purpose up to 1 year. এক বছর হয়ে গেলে we can stop clopidogrel, ticagrelor or prasugrel and continue with the aspirin alone. এটা হচ্ছে সবচেয়ে স্ট্যান্ডার্ড সেফ সিচুয়েশনস। নিউয়ার গাইডলাইন্স আর কামিং আপ, নতুন নতুন ট্রায়ালস আর দেখাচ্ছে যে নিউ স্টেন্সে এই ডুয়েল প্লেটলেটস বা দুটো প্লেটলেটস মিলে এক বছর না দিয়ে আমরা 6 মাস দিয়ে বন্ধ করে দিতে পারি, একটা দিয়ে অ্যাসপিরিনটা আমরা চালিয়ে যেতে পারি। এমনও কিছু কিছু রিপোর্টস আছে যেখানে আমরা 3 মাস পর্যন্ত দিয়ে আমরা অ্যান্টিপ্লেটলেট একটা বন্ধ করে দিতে পারি, দিয়ে অ্যাসপিরিনটা বাকি পিরিয়ডটা রেস্ট অফ দ্য লাইফ চালাতে পারি। তাহলে আমরা দেখছি উই আর ফাইন্ডিং দ্যাট উই মে হ্যাভ এ টার্গেট অফ ডুয়েল অ্যান্টিপ্লেটলেটস আপ টু 1 year, we have a target of dual antiplatelet up to 6 months or even 3 months. Whether we should go for dual antiplatelet up to 3 months or up to 6 months or up to 12 months will depend on what is known as a trade-off between thrombosis and hemorrhage. যদি দেখা যায় যে তার আগের বার স্টেন্ট বসিয়ে দুদিন বাদে স্টেন্টে থ্রম্বোসিস হয়েছিল, বা তার আগে একটা ইনফেকশন হয়েছিল আবার একটা ইনফেকশন হচ্ছে, বা ইফ আই হ্যাভ এভিডেন্সেস that this patient is particularly prone to develop thrombosis, in that situation I will not take any chance. I will go for 1 year dual antiplatelet treatment, and after 1 year only I will stop one of them and continue with the aspirin for the rest of the life. On the other hand, if I find that the patient had a history of gastrointestinal bleeding or major bleeding from any other sources earlier and is prone to develop bleeding more, in that case I may compromise to keep the dual antiplatelet up to 6 months or if necessary even up to 3 months. But these become more effective and safe when I am using the latest generation stent, because latest generation stents in many of the trials have shown to be safe when dual antiplatelets are taken off after 3 months or 6 months. So if it is latest generation stents and if the patient has a bleeding tendency, if I want to save the patient from the bleeding, I can take the chance at 3 or 6 months. The aspirin need to be continued. But in case of GI bleed, it should be the other way around. So in that case, I take off aspirin and continue with the other antiplatelets.
Okay, thank you.
And one situation is that there are certain antiplatelets which are more effective but has a greater chance of bleeding, like ticagrelor or prasugrel. So from the beginning, if I find that these patients are more chance of developing bleeding, I should choose the antiplatelets accordingly. so that it helped me take the decision as to when to stop one and continue with the other.
Thank you very much, Dr. Datta. Last question, I would like to ask Dr. Das, a very short reply from your end. What are the warning signs of ischemic heart disease? This is a question from Namisha Gupta. We have already, I think, answered most of the of this question, so a short reply from you.
Well, warning signs means if you are having breathlessness on exertion, হাঁটলে পরে শ্বাসের কষ্ট হচ্ছে বা চাপ হচ্ছে, অথবা মাঝে মাঝেই বুক ধরফর করছে, আবার অনেকে দাঁড়িয়ে আছে দুম করে পড়ে যাচ্ছে। এছাড়া কিছু কিছু পেশেন্ট আছে যেমন ডায়াবেটিস পেশেন্ট, সেই ডায়াবেটিস পেশেন্টের বেলায় চেস্ট পেইন হয়তো হবেই না, কিন্তু তার মাঝে মাঝে বুক ধরফর করবে, হাঁপ ধরবে, চাপ হবে। সেই চাপটা কিছুক্ষণের জন্য থাকবে কিন্তু আবার চলে যাবে। বাট যদি এটা চলতেই থাকে এবং ইগনোর করতেই থাকে তাহলে কিন্তু এটা একটা মেজর ইলনেসের দিকে, দ্যাট ইজ আমরা যেটা বলি যে হার্ট অ্যাটাক, সেই জায়গায় পৌঁছে যেতে পারে। এছাড়াও কতগুলো জিনিস আমরা লক্ষ্য করে দেখেছি যে ইফ there is increasing weight, if there is uncontrollable blood pressure, if there is uncontrollable sugar, diabetes mellitus তার কন্ট্রোল হচ্ছে না, then you get ready for impending problems in the form of ischemic heart disease or arrhythmia or even other form of heart diseases like heart failure and all.
Thank you, Dr. Das.
Dr. Mrinal, we have few questions from the audience also. So, who has a question from the audience?
Good evening, respected doctors and one other present here. Thank you for your valuable suggestions first. I am not into the field of medicine, but I have a question as a commoner that what is right bundle branch block? Because I heard that it is nothing to do with angioplasty. It cannot be cured by that, and it's a problem of generation of spark for the functioning of heart. How can it be addressed?
Dr. Ray, can you please?
It is not related to the blood flow of the heart, so it is not to do with the plumbing system, it's the electric system of the heart. We have got 3 wires for conducting current in our heart from one chamber to the other, electric wire. Right bundle is one of them. And if it is permanently faulted, either from birth or by a disease or scarring or whatever reason, it is reflected in the ECG in the form of right bundle branch block. It can be just a very innocuous chance finding, which definitely will affect your insurance policies and everything, but no health implication. But sometimes it reflects an underlying heart condition, which includes ischemic heart disease, which includes heart attack, which includes heart failure. So you cannot take right bundle branch block in isolation. You have to see the whole patient. If it is just a chance finding, you can safely ignore it, but you do some basic investigation and then you can reassure the patient. If it indicates an underlying heart disease, you have to treat accordingly. It does not per se indicate a pacemaker. That is usually the common question of a person that I have got a right bundle branch block, do I need a pacemaker? Answer is simply no.
Any other question? One last question.
Good evening, sir. My question is, what dietary changes should one make to reduce heart disease risk? So this is open to all if anybody wants to.
Dr. Banerjee?
Yeah, I think we have lightly touched this before. See, when by diet, there are certain things we have to keep in mind. Now we know that fat, for example, is not necessarily bad. Saturated fat, there are different types of fats. For example, saturated fats and unsaturated fats. Unsaturated fats are good. Saturated fats are not so good, but still you may need them. So you can take a bit of those foods who have saturated fat, and for example, you can have milk and you can have cheese. You can have them in moderation. Coming to protein, again, protein is good for your health, but at the same time, you shouldn't be having too much of processed protein. For example, protein is present in meat, protein is present in fish, and protein is present in eggs. But for example, the meat, if it's a processed meat, for example, that's available in the supermarkets, maybe in different forms. So this processed meats are not good. If you have meat cooked in your home with less oil, then it's probably not that bad. Similarly, the food you take, the way you prepare it is also very important. So if you have it, say fish, you are taking fish, fish is good for your health, but if you have it baked, it's better. If you have it fried, especially deep pan fried, then of course you are having a lot of oils with it, which is bad. So in a nutshell, and coming to carbohydrates, carbohydrates are also not good at all, especially those which are refined. For example, sugar. Sugar is not good, but when carbohydrates are present in complex form, such as in vegetables, they are not bad and they should be taken. Starch that's a complex carbohydrate, and that's something which you should take. So what I would say is, firstly, and now to come to your question, like how would you know what food and how much to take? Well, that actually you have to know a little bit about different foodstuffs, which food has high carbohydrate content, which has high sort of protein and which has high fat. But essentially from this sort of information you can make out, and also the nutritional content. What you normally have to have is a balanced diet, and by balanced diet we mean a major portion of your calories would have to come from carbohydrate, which is about 50%, and maybe 30% from fat and 20% for protein. That is the amount, but the quality is also very important. As I've said, the quality means like you should have more of complex carbohydrate, more of unprocessed meat, protein, and more of fat also. You should avoid too much of saturated fats. And trans fat is another thing which you have to keep in mind. A lot of things which are actually made in, say, in markets, and a lot of preservatives are added. These preservatives have high trans fat. And the trans fat is probably the worst type of fat that's available. And this is mostly industrial fat. Natural fats that's available in natural foods would not have trans fat. Trans fat is an industrial thing which is done to increase the shelf life of different foodstuff. And this trans fat is really bad.
Thank you very much, Dr. Banerjee. I think with this we are coming to the end of this program. Every good things come to an end. Today we had about 2 hours of very good discussion regarding heart attack, heart disease, cardiovascular disease. And I would like to thank our experts today, Dr. Deb, Dr. Dutta, Dr. Das, Dr. Ray, and Dr. Banerjee, for invaluable inputs, different aspects of the cardiovascular disease. I mean, 2 hours is not enough. We want to have more of this sort of programs in the future as well. And definitely also I would like to thank the audience, the person who are present over here, the person who are on live, for the active participation. We had some good questions coming up from these 2 quarters. With that, I would like to put an end. Thank you very much, and hope to see you soon. Thanks.